Thank you for this nice introduction. And could someone please take a picture so I can argument that the next circulation section should be in a bigger room. Having a council meeting this afternoon or this evening. So if we can take a picture. And thank you so much for this introduction. It's a pleasure to be here. We're going to talk about neonatal shock, hypotension, what is the pathophysiology and the assessment. First, I would like to disclose that these firms have put available some equipment for research, but I want to declare that I have no financial relationship with any of these companies. Well, what's the circulation for? Well, the blood is flowing through our body because of the delivery of oxygen and nutrients to all the tissues and the cells, and the removal of carbon dioxide and the waste products. And in a normal situation, there's far more oxygen delivery to the tissues than there is the oxygen demand within the tissue. And that's because we want to prevent a state of shock. And a shock that will occur when there's a cellular energy failure because of there is not enough oxygen delivery that satisfies the tissue oxygen demand. If we look at the oxygen delivery, how can you calculate the oxygen delivery? Well, of course, oxygen is transported by the hemoglobin, so you can measure hemoglobin concentration. Next to that, the hemoglobin has to be saturated with oxygen, so you can measure the oxygen saturation. Then you've got the cardiac output. That's getting more difficult because most people don't routinely measure cardiac output. And to a lesser extent, there's the partial pressure of oxygen. And as you see in the formula down below, it's just a minor contribution to the oxygen delivery. And what we do in our daily clinical care is that we try to assess the adequacy of the systemic perfusion by measuring all different kinds of parameters, such as blood pressure, capillary refill time, heart rate. We look at the color of the baby. We look at the urine output. We do some blood gas analysis, the pH, PCO2, base excess, lactate. If you are available to measure, you can do a central venous oxygen saturation. So we try to get an estimation about the adequacy of the circulation by having a look at all these different indicators. And this is from the HIP trial, and next to the blood pressure, which is most important, all the clinicians are looking at capillary refill time, urine output, as already told. Blood pressure is still the most important factor that's been considered by all clinicians. That is most important about trying to get an eye on the adequacy of the systemic perfusion. However, we know that blood pressure is not equal to the systemic blood flow or cardiac output because there's also the systemic vascular resistance. And you can have a perfectly normal blood pressure when your cardiac output is extremely low, provided that you have a very high systemic vascular resistance. So just thinking blood pressure is okay, there's no problem in this baby, that's not correct. And for a lot of different parameters, we know that it's rather subjective. The capillary refill time, blood pressure, combining different indicators of perfusion, they don't have that good predictive value for cardiovascular failure. So there's a black box, and we're trying to find out what's the circulatory status of that baby. And we just try to figure it out by doing all these clinical estimates. And with that, we try to think about, well, what should the cardiac output be in this baby? And we do that in our daily clinical care. Is that correct? Well, this is a study from the Pediatric Intensive Care Unit by Shane Tibby in London, and they had a blinded, very objective, absolute measurement of cardiac output. They used the transpulmonary thermodilution, it's the PICO catheter. we can't use it in newborns. But they had a measurement in all those patients, and they asked the clinician to estimate what the cardiac output is in an absolute value. Of course, that's very difficult to say, well, I think this cardiac output is so much ml per minute. But they also asked to categorize it and to estimate, is cardiac output low? Is it low to normal? Is it normal to high? Or is it high? And they could use all the variables we just discussed: heart rate, blood pressure, capillary refill time, lactate, central venous oxygen saturation, blood gas analysis, everything we do. And with that comprehensive interpretation of all these different parameters, we think we should be able to do so. But what was very astonishing, that only a quarter of the patients in the true deep shock were categorized as being in a low cardiac output. But I always thought, well, the really low cardiac output kids, I must be able to recognize that clinically. But it's not possible on a pediatric intensive care. You can say this is only one study, but such a study has also been done by Egan, has shown the same results. On an adult intensive care, same results also. So it's probably not, we're not as good as we would be, or we think we are, in estimating on a clinical way, in estimating the cardiac output. And we're trying to find out whether the newborns are an open book for us, and that we as a neonatologist, we are very good. We're not as the pediatric intensivist or the adult intensivist, but I'm not sure whether that's right, so we're trying to figure that out. We all know about the different stages of shock, and the first stage is a compensated shock. Whenever there's a problem in oxygenation or in perfusion, blood is derived from the non-vital organs and perfused to the vital organs. And in this situation, by manipulating the systemic vascular resistance or the regional vascular resistance, it's supposed to be that the blood pressure stays in a normal range. And we want to prevent a uncompensated shock when all the redistribution phenomena are failing and also the vital organs are in a low perfusion or are in a low oxygenation. We normally have this division between the vital organs and the non-vital organs. The vital organs, the heart, the brain, and the adrenal gland. The adrenal gland, because that is where the redistribution phenomena comes from. But probably in the preterm infant, the forebrain isn't a vital organ, because there are data that suggest that the vasculature to the forebrain are constricting in a state of shock instead of vasodilating. So it's a brain stem that's a vital organ, but probably the forebrain isn't. And that might be a problem. What are the data for this? These are from fetal lamb studies. And what they did is they decreased the arterial oxygen concentration. And what you see, if you decrease arterial oxygen concentration, there's increase in the cerebral blood flow. But what you can see is that the increase in cerebral blood flow is mainly to the brain stem and not to the cortex. And here you can see the difference between the brain stem and the cortex. So blood is mainly perfused to the brain stem at the expense of the cortex. Also, when you see in this lamb study, if you have the relationship between the cardiac output on the x-axis and the cerebral blood flow on the y-axis, you get a decreased cardiac output. There will, at the end of the autoregulation, there will be a decrease in cerebral blood flow. But there's also differentiation between the blood flow to the cortex and the brainstem. This is a human study looking at fetuses with an intrauterine growth retardation, growth restriction, and with group 1 to group 4, the more hemodynamic problems in the mother and therefore within the fetus, what you see is that there is a decrease in the blood flow to the frontal cortex and an increase in the basal ganglia and the cerebellum. That's a Doppler flow measurement, and probably this is representative of the brain stem. So instead of waiting for a decrease in blood pressure, because when blood pressure is okay, that isn't the problem, well, maybe that's not right. Shouldn't we, instead of waiting for the uncompensated shock, try to aim to already to detect the compensated shock? And I think that's possible. So we always have, there's the pressure-based approach. It was published by Gupta, and this is the approach that is mostly being used throughout the world. A lot of doctors say, no, we don't do that. If you ask the nurses, they always say, this is the way the doctors work. And in my opinion, nurses are always right. When there's a problem in a baby, we start by volume expansion. We give normal saline. It works, but only for 5 to 10 minutes. Maybe we've given too less, so we repeat it and repeat it. But it doesn't help the problem. It doesn't give the solution. If that doesn't work, we start dopamine. If that doesn't work, we start dobutamine. We don't stop the dopamine, we still continue it. Isn't that strange? We keep on giving a medication that's not effective. Whatever medication we give and it doesn't work, we still continue. It's not a drug that's, it's safe, we just give dopamine. So I think if it doesn't work, you should stop it. So dobutamine, if that doesn't work, we've got a problem and we've got to think what's going on with this baby. So I don't think that's the way to go. I think we have to open the black box and go to a more physiologic-based approach. Try to find out what's the problem in this baby. Instead of a one-size-fits-all protocol, go to an individualized management. And that is possible because I think if you got blood pressure, and that's on the x-axis, and you've got the central blood flow on the y-axis, there are 4 quadrants. If you got a normal blood pressure and a normal flow, the baby must be in a good situation. If you got a low flow and you've got a normal blood pressure, this probably is a baby in a compensated shock. If the baby has a low flow and also a low blood pressure, I think this must be an uncompensated shock. And the last quadrant, if you got a normal or high flow and a low blood pressure, this probably is in hypodynamic circulation. And in this way, you can differentiate about what is the problem in this baby. So that's very nice, and I'm talking about measuring the blood flow. Is that possible? Is it possible to measure cardiac output? During my training, I was on the adult intensive care. I saw patients lying there with Swan-Ganz catheters, just having the cardiac output on the monitor, and I was stunned because when I was a resident and a fellow, there was nothing about cardiac output on the monitor on the neonatal intensive care unit. So why not? Because it wasn't that good possible. It was not possible to measure cardiac output. I think it is possible. There are many techniques available for measuring cardiac output in critically ill patients, but most techniques are not feasible in newborn infants. And that's because it's very complicated, because of size restraints. This shows a Swan-Ganz catheter. Well, it's obvious you can't use that in a preterm infant, but also a transesophageal probe. It has the same size as the forearm. So there are the size restraints. Most techniques you can't use because of the presence of shunts. The problem in our patient population is they have obligatory shunts, the transductal shunt, the transatrial shunt. So most techniques aren't feasible, aren't usable in the infants. And there's the problem of the indicator toxicity. I'm not very keen in injecting lithium into a preterm infant if you want to use the transpulmonary lithium dilution method. So. And also there's a very elegant way of the rebreathing technology you can use to calculate cardiac output. You have an extra circuit in your ventilator and you let the baby rebreathe. So there will be an increase in carbon dioxide, and there you have it, an increase in carbon dioxide. That's what we want to prevent because of the influence of the cerebral vasculature. So also that CO2 is then a toxic indicator if you want to use that for cardiac output monitoring. There are many, many methods available, and I think there are 4 methods that are applicable and feasible in newborns. The transthoracic echocardiography, transpulmonary ultrasound dilution, the bioimpedance technologies, and maybe in the future the pressure recording analytical method. And I will shortly address these methods. We all know the NPE, the neonatologist performed echocardiography. It started, they're all different names: functional echocardiography, targeted neonatal echocardiography. We all aiming for the same, trying to see what's going on in the baby instead of having a black box. It's increasingly being used by neonatologists in clinical practice. And you can measure cardiac output, but you should know what cardiac output are you measuring. Are you measuring right ventricle output? Are you measuring left ventricle output? Are you measuring descending aorta flow? Are you measuring SVC flow? It matters because different, if there are shunts, they aren't all the same. If you measure left ventricle output and there is a transductal left to right shunt, it will overestimate the systemic blood flow. If you measure right ventricle output and there's an interatrial left to right shunt, it will overestimate the systemic blood flow. SVC flow is very nice. I think it's more for research purposes, but you should be aware it's not cardiac output, it's cardiac input. And it's not total cardiac input, it's partial cardiac input. Namely, it's the cardiac input from the upper body. You can measure it. You can measure, for example, from the left ventricular outflow tract, the cross-sectional area, and you can measure the stroke distance if you measure blood flow velocity through that outflow tract. And the area under the curve is called the velocity time integral, and it tells you the stroke distance. What is the distance one red blood cell is propelled into the circulation during one heart cycle? That will give you the total of the stroke volume, and if you multiply that by the heart rate, you will have the cardiac output in this formula. But there are some pitfalls because it's not that easy to measure the outflow diameter, or better, you should have the cross-sectional area. It's not a static, not an ideal round-shaped vessel, not always lamellar flow. Well, all these pitfalls result in an error percentage of plus minus 30% with the echo. And that's what we're using a lot in clinical care. So we should be aware of that. Another technique is the indicator dilution technology. If there's an unknown volume in this bucket, but you know the concentration, you can add an indicator with a known amount, and then you can measure the concentration again, and from that you can calculate what the volume is. And that can be used to measure cardiac output with the indicator dilution technology. First, you have a known amount of indicator that's injected into the circulation. There's mixing and dilution of the indicator in the heart, and then you have to detect it downstreams, and you record the concentration over time, and that you can use in the Stewart-Hamilton equation, and it will get you stroke volume and cardiac output. The transpulmonary indicator dilution technology is something we validated in the animal lab, and it has an error percentage around 15 to 20%. Anything below 30% is clinically acceptable, is the general consensus. I'm not sure whether should we aim for a more precise and accurate way. But what we do with this method, you have to use an extracorporeal circuit. You have to connect it to any arterial and central venous line. It has been proven that it doesn't influence the systemic and cerebral hemodynamics and oxygen parameters. You inject an amount of 0.5 or 1 ml per kilo of isotonic saline in a normal body temperature. It's injected on the venous side, is detected by the venous sensor, goes through the baby, goes back through the arterial line, and you can detect a decrease in ultrasound velocity caused by the normal saline. And with this is an indicator dilution curve with the area under the curve, the Stewart-Hamilton equation, you can measure cardiac output. But it's not non-invasive. You don't have to put in extra material, but you still have to connect it to interarterial and central venous catheters. The other technology that's quite exciting is the bioimpedance technology. It's non-invasive, easy to apply, just some sensors you have to stick on the body. First I was taught that it was developed by NASA, but during one of my presentations in Russia, I was corrected. The Russians were first. And they truly were. And that shows the bias we're in, because we only have entrance to Western PubMed, etc. But they showed me that already in 1949, the first study about the application was done by a Russian. So I will put on both organizations down here. And the NASA used it to measure and to analyze the effects of zero gravity on the cardiac function in astronauts. There are all different kind of monitors. It's the electrical cardiometry from Escalon, it's the bioreactance by NICOM, it's the regional impedance cardiography by NICAS, all different types. What it does is the changes because of the heartbeat and the stroke volume, it gives changes in bioimpedance on the thorax or throughout the body. And they are making an algorithm to translate that from the changes in bioimpedance to stroke volume. Of course, that's not a linear relationship, so that's complicated. That's why you're not shown that exact formula. It's patented, and I'm not sure whether it's very accurate. There are some data, if you compare it to echocardiography, it's not, there's no good agreement. But the fact is echo the best gold standard reference method? I don't know. So we should validate these monitors against a good, true reference method. And wouldn't it be great if you got an arterial line, and there must be a correlation between the area on the curve of the arterial pulse and the stroke volume. Also, that is being analyzed, and that would be great if from that way we can measure stroke volume and measure cardiac output. That's very complicated, especially in newborns. It's getting done in adults, but well, the specific anatomical and physiologic characteristics of newborn infants makes it very difficult. So all different kind of techniques. I think if you want to have accurate and non-invasive, the ideal method is the cardiac MRI. Well, the patients we can take to the cardiac MRI are not possible to take over there. So the transthoracic echocardiography, the thoracic electrical bioimpedance probably are the best, or you've got the invasive, the transpulmonary indicator dilution method. What we want is to get a individualized medicine, individualized hemodynamic management. If you're able to measure blood flow, if you're able to measure blood pressure, you can have this algorithm. Low systemic blood flow, systemic hypertension. You can differentiate between, is it the problem in the diastolic blood pressure, systolic blood pressure, or the combination. It's a very busy slide. Please, it's not the but you can try to find out what's the real pathophysiologic problem in this baby. Is it the problem in the afterload? These are the possible causes. Is it the preload? Is it in the systolic pressure, contractility problem, or afterload? And from that you can consider all different kind of treatments. So in this way, if you measure blood flow, blood pressure, you can try to figure out what is the problem in this patient, in this specific patient you're taking care of, and instead of giving a one-size-fits-all treatment, try to find the best way how to treat this baby. Because next to the ventilator, I would like to introduce the circulator. It's very sophisticated, because if you know what's the problem in that baby, the heart is not pumping right, I have to increase the contractility, you just turn the knob. If the problem is a severe sepsis with vasoplegia, a very low systemic vascular resistance, you just have to turn the knob of the vasopression. Of course, this is very cheap because this is in your head. You can use this already. So try to figure out what's the problem and try to treat the babies according what's the problem in that baby. Of course, this is very nice. It's all theory. And we have to prove that when we do a pathophysiology-based management, that will improve outcome. Because it's not the monitoring that will improve it, it's the interpretation of what the monitoring is telling us, the accuracy, the precision, but also the coupling to the therapy. I can monitor very good, I can interpret it in a very, very good way, but if I do the wrong treatment, it won't improve outcome. That brings me to the summary. Let's treat patients, not numbers. For example, the blood pressure. Well, it's our daily practice, but unfortunately, our clinical estimation is not as good as we think we are. Maybe we can prove that the premature baby is an open book, and of course, in the premature baby, we can perfectly see it, but I'm not sure. I think we should assess blood pressure and blood flow for an individualized hemodynamic management. I think that might be beneficial and might reduce morbidity and mortality, but we still have to prove that. And again, if you got a normal level of cardiac output, that won't tell you that every organ is getting enough blood. It will tell you only about the global perfusion. It's not the advanced hemodynamic monitoring that will improve outcome. It's the correct interpretation of the acquired variables and the resultant therapeutic management that may improve